Hi everyone, my name is Varun, and today I'll be presenting on the journal article Biomechanical Influences of Gait Patterns on the Knee Joint, a Kinematic and EMG Analysis. And this is from the journal PLOS One, which has a relatively high impact factor of 3.24. So first of all, the research question for today was, how does lumbar spinal stenosis, LSS, affect both gait pattern and surface EMG signals, particularly in the coronal plane? And the purpose of this study was to understand the effects of LSS on gait pattern metrics, such as stride width and femorotibial angle, for example. And then studies of gait pattern on LSS patients in the coronal plane specifically have never been conducted, and this can help establish some causal links. So before we move forward, here are some terms that are used often in the paper. So first, we have the sagittal plane in the middle. This is what a lot of previous studies have measured, and they measure angles in anterior to posterior fashion. So when you bend your knee and what you typically think of bending your knee, that angle is what is measured. And in the coronal plane, more medial to lateral, so like left to right angles are measured that way, and that's what this study focuses on specifically with the femorotibial angle. And then what is LSS? It's a significant reduction in space in the lumbar spinal canal, and it can affect neural and vascular supplies to the lumbar region and the nerves and the muscles that it innervates. So first, next to literature evaluation, there are 34 cited sources, most with an impact factor higher than 3, none under 2. And however, the majority of sources cited are greater than 10 years old, but a lot of those inform us as far as the pathology, medical and surgical management, diagnosis, and some of the LSS and gait biomechanics that are important. More recent studies within 5 to 7 years focus on LSS studies with various methodologies, patient reporting, gait analysis in the sagittal plane, as I mentioned before, and then analyzing muscle strength. All the methods from cursory analysis have good sample sizes of over 30 and solid methods similar to this paper. The sources cited help inform the paper either with critical background information or past studies that help show the state of the field and expose the research gap well. So moving into the study now, here the subjects there were 37 of them, 17 with LSS, and then 20 healthy adults without those LSS symptoms. The inclusion criteria to be included in the LSS group were pretty specific. Independent ambulation, so walking on your own is required, age over 50, Hufschmidt grade 1, so this refers to the severity, a decent severity of observed clinical signs pertaining to LSS, greater than moderate stenosis in the lumbar region as shown by MRI. And then for inclusion in the healthy control group, only criteria was to be a healthy adult free of LSS symptoms, which did cause some issues with matching. Exclusion criteria were not explicitly specified, which may have hurt the study a little. As far as sample representativeness goes, I believe that there were some issues. Their gender of the majority of the subjects were mostly female. And then there was some selection bias. It appears that this could be due to the poorly defined inclusion-exclusion criteria. The control group was significantly younger and significantly taller, though the height issue was taken care of with a future calculation that I'll mention. As far as method and design goes, this was a prospective case control study, as I mentioned in the paper. And then overall, IRB approval was obtained, and subjects' rights appeared to be protected throughout the study. And so as far as how the study was conducted, first stride width was measured using the FreeStep software, and then stride width was divided by height to account for the significant variations in height. And then 4 trials were done. Only the last 2 were counted, and that helped minimize confounding with subjects getting used to the sensors and the paths that they had to walk. And then subjects were also then asked to walk in 3 gaits: normal, adducted, so that's feet together, and abducted, so that means feet far apart. Each of the gaits were repeated twice, and subjects walked a distance of 6 meters per trial. And then surface EMG signals for those 3 muscles listed there were measured, as well as limb alignments, and so that's a femorotibial angle, which I'll show soon, in the coronal plane was measured. So this figure shows the sensor placement to measure femorotibial angle. and then subjective ratings of discomfort during each gait cycle were also obtained. So here is an illustration of what the femorotibial angle actually is. So here on the left we have the normal gait, and on the right we have what's the abducted gait. So this abducted gait right here, this angle measured right here is the femorotibial angle, and so this is what's called a varus, when the joint kind of bends inward, and so this angle can help show things like knee stress and mechanical loading, which I'll discuss later. So overall, the study design was appropriate. It sought to measure the stride width, electrical activation of 3 important muscles while walking, the FTA, and femorotibial angle and subjective discomfort, and it appropriately accounts for confounding variables well with test trials, multiple trials, and appears to help answer the research question. As far as data analysis goes, the SEMG data, the peak signal and the root mean squared signal were both recorded and analyzed later. For the femorotibial angle, the maximum during the mid-stance phase, which is one of the major parts of the gait cycle, was obtained. And then also to compare control and LSS groups as far as data analysis goes, a 2-sample t-test was performed, and it was appropriate as that is what should be used to compare two groups of averages. And then for comparing the 3 gaits within groups, so within the control group and within the LSS group, ANOVA was used, which is what is expected as we are trying to compare and establish significance between 3 different groups of means. For the most part, the results were statistically significant, and a p-value of 0.05 was used. Here are some notable specific findings. The tensor fasciae latae muscle, which is one of the muscles studied, was significantly more activated in the LSS group, regardless of gait type, which shows that there is some potential additional muscle recruitment with the disease. And then quadriceps femoris activity was significantly lower for the LSS group, which is also important because it may show the effects of LSS. And then gluteus medius, aside from the abducted gait, did not appear to be significantly different between either group. LSS group was obviously found to have significantly more perceived discomfort at the gluteal region and the knee joint, the 2 regions measured for that specific stat in all 3. And then the FTA angle was significantly different between the normal and abducted gaits, femorotibial angle. So here are some of the important findings in chart form. So with this first figure here titled femorotibial angle, the normal and abducted gaits were significantly different in femorotibial angle in comparison to the control. And then for this second figure here, this red box with the hashtags shows that the tensor fasciae latae TFL muscle was significantly more activated in comparison to the control, and the quadriceps femoris was significantly less activated in comparison to the control. The hashtag symbols mean there's a significant difference between groups, so between the control and the LSS group, and the same idea here. Overall, the findings of the study were presented very clearly in both table and chart form in the paper. And so the author's interpretation was that this was a novel study on joint angles in the coronal plane, coupled with the relative activation of different leg muscles, and it helps show a potential link between knee osteoarthritis and gait pattern. Some limitations of this study were that there was no age matching, gender differences were unable to be elucidated, and this was a single session study. So a longer term study would likely be required to better establish the causal link between a significantly different femorotibial angle and knee osteoarthritis in LSS patients, for example. And then finally, as far as the significance goes, here are some implications. It is the first of its kind, specifically with its studies in the coronal plane, and may help establish a causal link between gait pattern in LSS patients, so the abducted gait, and knee osteoarthritis. So back to that free body diagram type picture that I showed in the beginning of the presentation. Contribution largely the same. It was the first to study the biomechanics of LSS and gait, specifically in the coronal plane. So again, that femorotibial angle was one of the critical major novelties of this study. And replicability, this study could easily be replicated. There are detailed methods provided and well-established sensors and algorithms that can reliably obtain all this required data. Lastly, some additional questions. How could a long-term study better elucidate the link between LSS, gait, and knee osteoarthritis? That's something I'm interested in seeing. How does gait and mechanical loading on the knee change with age? And then, are there significant differences in LSS presentation, gait, muscle activation, femorotibial angle, for example, between men and women? That's all. Thank you.